Great.
Okay, I'd like to introduce Dr. Rashmi Sharma, who is an associate professor in the Division of General Internal Medicine and Director of Equity, Diversity, and Inclusion for the Cambia Palliative Care Center of Excellence at UW-Medicine. A board-certified palliative care physician and health services researcher, she has led the Impact or Improving Palliative Care Together research program, which seeks to provide care, improve care for patients with serious illness, particularly those from culturally and linguistically diverse community. As part of this work, she currently leads 2 large studies to improve palliative care for patients with preferred language other than English and dementia or cancer. And so I think you can see she has tremendous expertise to share with us today on cultural and linguistic challenges in palliative care. Welcome, Dr. Sharma.
Thank you so much. Thanks for that lovely introduction. And I am really excited to be able to talk with you all about this really important and timely topic. I do want to acknowledge some of the funding sources for my research, and I'll reference some of this work as I'm going through the talk. Okay, so the plan for today's talk is that I'm going to start with kind of what we're talking about, meaning defining some of these key terms around language and culture. Then I'm going to kind of talk about who we're talking about. So I'll provide some demographic data for the US population. And then I'll review some of the drivers of disparities with a focus on populations with limited English proficiency. Then I'll shift to a more kind of practical aspect around some of the communication strategies that we can use to improve care for these populations, with a special kind of focus on some of the best practices in thinking about working with interpreters. And then I'll kind of end by talking about some additional multi-level solutions. Some of that's really informed by our research, but how do we really start to move the needle in addressing disparities for these populations? Okay, so why are we talking about culturally and linguistically diverse populations? Well, as I think you all know, the older adult population in the US is becoming increasingly diverse. And effective clinician-patient-family communication is so central to high-quality primary care, and I would say even more critical in the context of serious illness. And so when you have things like culture and language that directly impact communication, that can really drastically affect care. Now, we'll find, and especially as I review some of the literature on this topic, that cross-cultural communication and language barriers can really impact all aspects of care and increase challenges across all of the 4 M's, though I'm really going to zoom in onto the what matters aspect of those 4 M's. And that kind of brings us to palliative care in general. So palliative care, which is specialized care for patients with serious illness, can really help to elucidate what matters to patients and families. It can also, though, optimize symptom management and really help to improve quality of life, but it really needs to be done in a culturally and linguistically appropriate way. So what are some of the ways in which we can deliver this important high-quality care to older adult populations as they navigate serious illness? Okay, so where does culture and language kind of fit in as we think about impacts on health outcomes and on quality of care? Well, you can see in this graphic on the left side are domains of influence, and across the top are kind of these multi-levels informed by the socio-ecological model. So we have the individual level, then we have the interpersonal level, and within that we're including healthcare interactions, the community level, and the societal level. And you can see that the socio-cultural environment domain, which includes the things that we're going to be talking about, particularly identity, English proficiency, experiences of discrimination, that kind of goes across all of these levels of influence, again, to impact the experience of care that patients and families have, the quality of care, and their actual outcomes. Okay, so some key terms so that we're all on the same page as we're talking about this population. So I want to start with limited English proficiency, which really comes from US Census Bureau data. So on the census, people are asked, how well do you speak English? These are the choices, and any response that's less than very well indicates limited English proficiency. But in the healthcare context, we're generally not assessing people's proficiency. Rather, we want to know what language they want to talk to their healthcare team in about their care. And so here is the question that we use within UW medicine. The default answer to this is unknown. So you have to specify a language, including English. And if you specify a language other than English, or LOE, that is kind of how we define a limited English proficiency equivalent, but in the healthcare context. So that gets us to kind of this mix of terms then. So limited English proficiency, I'm going to use that term in this talk when I am talking about demographic data. Then LOE or PLOE to get at what we're really generally eliciting in the healthcare context and focusing on. The other thing I really like about this LOE term is that it really moves us away from the deficits framing that is inherent in that limited English proficiency term. And it's just more accurate, right, when we're talking about clinical encounters. There's also a term non-English language preference, which I've seen in some literature, but not as commonly used. So I just mentioned that in case you see NELP written somewhere, that is also meant to get at this same population. Okay, so as we look at US Census data, so I'm going to talk about limited English proficiency here, you can see some of the most commonly spoken languages in the US. And for those languages, as you look here towards the bottom of this chart, you can see that more than 50% of people who speak some of these languages report limited English proficiency, and that's denoted by the orange, green, and purple bars. So the takeaway here is that we have a growing population of people with limited English proficiency. We need to know how to provide high quality care for this population. To zoom out a little bit and look at both the US and then Washington state, if we look at foreign-born population for the US, this is from 2022 data, you can see the geographic distribution. So that currently is at about 14% of the US population is foreign-born, of whom about half report limited English proficiency. So that gets us to just over 25 million individuals. You can see that on the map, the states that are blue and then moving to dark blue have larger percents of the population who are foreign-born. And you can see Washington there is in one of those top 10. So as we kind of speak a little bit more about Washington, there are more than 580,000 residents in the state of Washington who report limited English proficiency. Again, we're drawing from US Census data, of whom more than 110,000 adults are aged 65 or older. Now, what's really interesting about Washington is the diversity that is represented here. So you can see that about half of those individuals with LEP have a primary language of Spanish. That's followed by Chinese, Vietnamese, Korean, Russian, Tagalog, African languages, and then about 20% speaking other. So it's really a wide mix of languages that are spoken by individuals in our area. And Harborview Medical Center, for example, sees patients who speak over 140 different dialects and languages. So a really diverse patient population that we see. Okay, I'm going to shift for a second to defining culture. Now, for most of this talk, I am going to focus more on limited English proficiency, again, because that brings up unique challenges when we are talking about communication and understanding what matters to patients and families. But culture is the backdrop for a lot of that. And it's the intersection of culture, language, and sometimes literacy that creates the most barriers for some of these populations. So a little bit about culture. Now, in the context of serious illness and palliative care, culture is so important because it can influence beliefs, communication, preferences around decision making, and really the meaning of illness. Again, really something that is paramount in importance in the context of serious illness. Importantly, culture is not static. It is continually evolving. What has also been evolving is the way in which we have approached culture within the healthcare context. And what I would say over the last couple of decades kind of was more of a focus on cultural knowledge. So trying to understand specific characteristics for a given population, that moving towards awareness and sensitivity. So that is recognizing that there may be similarities and differences between different groups, but not placing a value judgment. Building off of that, we kind of advanced to thinking, well, that doesn't seem like enough. Cultural competence seems more important. We need to know how to deliver culturally appropriate care. The thing, though, with all of these, cultural knowledge, awareness, sensitivity, competence, they're really focused on content. This idea that maybe you can just know enough about a specific culture in order to provide high quality, culturally competent or appropriate care. The problem is, as we all know, within any culture, there's a whole spectrum of preferences and experiences. This can also really lead to stereotyping, a sense of othering, because it really kind of creates this dynamic where there's kind of a white male heteronormative standard, and everybody else is someone else that we have to learn about. So the shift then was really towards cultural humility. So the idea here is let's move from content, because it is really not realistic to expect that all of us can somehow become experts in all different cultural backgrounds, right? So let's move from content to process. Here, we're really elevating the patient's expertise. We're trying to understand for this patient and family who is in our exam room or in our hospital room, what are the things that are important to them? It really helps to kind of have more of a shared power structure. And the key pieces here are one, self-reflection. So recognizing that we all bring certain things based on our identities and our life experiences to any encounter that we are having with a patient and family. So some reflection of what are we bringing into this encounter, and then really approaching things from a place of curiosity. Again, the idea here is to understand for this patient and family, what do you need to know to help deliver the best possible care for them, right? And at the end of the day, they are the people, the patient and family, best positioned to tell you that information. All right, so bringing it kind of back to this multi-level framework, I just want to really drive home the point that then culture and language affect each of these different levels, whether it is the individual level and you're thinking about the patient or the family member, an interpreter, a clinician, the clinical encounter where all these individuals are coming together, the healthcare system as a whole, and the community setting as a whole. And again, kind of later in my talk, I'm going to come back to this idea of these multiple levels and think about how we can really provide more sensitive, high quality care across all of these different levels. Okay, so with that kind of setting the stage done, I want to move to what do we know about the quality of care that patients receive? And again, kind of really focusing in on those with limited English proficiency or preferred language other than English. So what we know is that patients and from these populations and their families really experience disparities in multiple areas. And again, I'm going to kind of focus on some of the areas that are most relevant as we are talking about older adult populations and serious illness. One is the suboptimal assessment and treatment of symptoms. A big one, though, is around unmet informational needs. So patients and families not being informed of or not fully understanding such important things as diagnosis, prognosis, treatment plans, side effects, available resources. Now, you can imagine if you are not being informed of or not fully understanding these important concepts, it's really hard to make informed decisions or to really engage in shared decision making. And all of this really leaves patients and their family members feeling vulnerable, disempowered, frustrated, and having a difficulty communicating such important things as adverse effects that they may be experiencing. Now, even in systems that have more robust access to interpretation services, these services may still be lacking in key patient areas, including patient registration, pharmacies, and even in operating rooms. If we look at the outpatient setting, we can see, and this study was focused on older Latino and Asian immigrants. Just to orient you, the LEP category is what we've been talking about. EP is English proficient. EO is bilingual, so they're speaking English and proficient both in English and in their primary language. And you can see here that for patients with LEP compared to the other groups, they are much more likely to have difficulty understanding the doctor, difficulty understanding written information at the doctor's office, difficulty reading instructions on a prescription bottle. When we look at inpatient care, and particularly in the end of life, these are data from UW Medicine that our team looked at. We find that for older adults with serious illness and limited English proficiency, they're more likely to have 30-day readmissions, more likely to have emergency department visits, and more likely to die in the hospital than those without LEP. They're also less likely to have completed advanced care planning documentation. So one of the key issues here with these kinds of data, these data that show a higher utilization of healthcare, particularly at the end of life and higher intensity care, what we can't tell from these data are to what extent does this utilization pattern reflect preferences? Those preferences, of course, could be informed by things like cultural norms, religious beliefs, etc. And to what extent do these utilization patterns reflect poor quality or suboptimal communication? So a lot of our current work is to try to kind of tease that apart. But regardless, I would say one of the important takeaways for me from these data are that as we think about interventions to improve care for these populations, one important place to be thinking about is the hospital, including transitions to and from the hospital. Okay, so why do we see disparities in the quality of care for these populations? And again, as we think about the extent to which communication could be driving some of that higher utilization and higher intensity, well, one of the key reasons has been the underuse of interpreters. In this study that was done at UCSF, in a place where they had robust interpreter services, you can still see that in the hospital setting at the time of admission, 43% of patients had no interpreter of any kind. That includes not having family either, who should not be interpreting, but often are. So no one at the bedside in that conversation with the physician at admission. You can see with nurses during the course of the hospitalization, 63% of patients not having an interpreter of any kind present in those interactions. Now, we all know that we should be using interpreters. And as these quotes from this qualitative work point out, some of the reasons why we try to kind of get by and sometimes not use an interpreter even though we know better are things like the time pressure, right? Or thinking that maybe you know a couple of words, so maybe it's enough to kind of, again, make things work or get by. But what I think is important in this bottom quote is the recognition that when we do things like that, and I'm going to read this quote, this resident saying, "I feel guilty because I feel like I'm not doing my job. It also makes me feel very frustrated and upset at how our hospitals and clinics are run, that we allow this to happen. There's a lot of sentiment that, well, maybe patients with LEP shouldn't be getting health care. I think the reason that I feel badly is because I know that I'm not giving equal care to my patients." So again, this recognition that in order to deliver on the promise of high quality, equitable care, we really need to be making sure that patients and their families understand what we're talking about with them and that we can fully understand what they're trying to say. Okay, so one problem is this lack of interpreter use. And when we kind of narrow in on the context of palliative care and end of life, we see data showing that providers frequently rely on family, including minors, to interpret information, again, about super important and complex, hard things like diagnosis and prognosis. And that when professional interpreters are not used, patients and families have an inadequate understanding of diagnosis and prognosis. Patients had worse end-of-life symptom management, and families experienced emotional conflict and distress, particularly when they were the ones who were having to do some of this difficult interpretation. In addition to the lack of interpreters, we also see that even when interpreters are present, the quality of communication may still be suboptimal. So these are data from an Australian study where they looked at patients with interpreters and without. 23% of physician statements about prognosis were not interpreted. Of the statements that were interpreted, 27% were not interpreted accurately, and 59% of patient and family prognostic statements were not interpreted. And to give you an example of kind of the stakes that we're talking about here, the quote at the top, the doctor has said, "We think there's a 40% chance that the treatment will prolong your life." So quite a bit of specificity in there around prognosis. The interpreter is saying the treatment will prolong your life. You can see there this critical piece of information getting completely lost in that translation. The other thing that's interesting, though, about this study is this finding around how oncologists used more jargon with immigrants with interpreters. So maybe this assumption that the interpreter will do the hard work of simplifying complex information. They also made fewer statements of hope. So again, we see here that even when interpreters are present, that is changing what we're saying and sometimes how we're saying it. From the interpreter perspective, interpreters also talk about some of the challenges and kind of missed opportunities for clinicians and healthcare team members. One is around the lack of pre-meetings. I'm going to say more about that. Two, rarely receiving feedback, not being able to debrief with the clinical team, and often not feeling that they're treated as part of the medical team. Some of the other challenges that came up in this work, again, this is really focused specifically around palliative care conversations, the conflict between strict interpretation and cultural brokering, right? So for the interpreter, how much do they need to say exactly what the clinician said versus to communicate the meaning of what the clinician is trying to say? And then, of course, palliative care jargon being especially hard to translate. So some of these terms really don't have equivalents in other languages. And frankly, they are really complex concepts to try to talk about in English with native English speakers, right? Things like code status, do not resuscitate orders, hospice. Again, really complex concepts that many people have misconceptions about regardless of language. Okay, so now I want to shift a little bit from some of that research piece, some of what we know from the literature out there, to kind of thinking about some of the challenges that we encounter in the real world as we are having interactions with these patient populations, and kind of talk about some effective strategies to better work with interpreters when we're seeing patients and families. Okay, so step one, so again, kind of practical approaches here, is really assessing the need for an interpreter, right? I just talked about how one of the drivers of disparities for this population is the underuse of interpreters. So we got to start with making sure that we recognize when an interpreter is needed. So super basic, checking the medical chart to see the patient's preferred language for medical care within UW Medicine in our EPIC system, right on that cover page where the demographic information is for the patient is in bold the patient's language. Again, pointing back to that kind of early slide, saying that every patient in UW Medicine is asked that question about what is their preferred language. So that's there in their chart. Also important to ask the patient and family about what language they want to talk to their healthcare team in. Now, an important thing is to remember that being conversational in English may not be enough to understand medical jargon. And here we have the opportunity to really help normalize for patients and families the need for an interpreter to help with complex conversations, right? We are not making a judgment on their level of proficiency. We're trying to ensure that the communication and care experience, I would say, is as comfortable as possible for the patient and family, and they can really understand everything that is being discussed, and recognizing that medical conversations can be hard to understand for everyone. The other piece in here is really thinking about how the presence of an interpreter can help to reduce some of the burden for the family member, right? Talking about, as I pointed out on that other slide, when we think about some of the emotional distress that some family members are experiencing when they're having to do both the interpretation and make the judgment calls about what to say and how to say it, as well as being a family member in that visit, that can be really hard. Now, at the same time, we definitely see that many family members may want to act as interpreters. That includes kind of resisting this idea of a stranger being in the interaction, especially when we're talking about sensitive conversations, topics where there may be stigma, etc. This is particularly relevant as we think about some of the populations with less diffuse languages. So where you may have a smaller, tight-knit community, fewer interpreters, and those interpreters then are a part of that community. So people worry that if the interpreter kind of hears something, that may then get out to other members of the community. So we really want to reassure patients and families that the interpreters are protecting the confidentiality of what is being said, and that nothing that is being discussed in this clinical encounter is going to be talked about outside of the encounter, and that our interpreters are certified and trained to maintain that level of confidentiality. Also mentioning that interpreter services are free to the patient and family. I didn't write that here, but I wanted to make sure that that point kind of came across. Having said that, there are still many occasions in which family members feel like, for many reasons, that it would be best that they interpret. And as we were doing some of our research, where we were interviewing interpreters and cross-cultural mediators, I'll mention that program a little later, we had one of our interpreter CCMs give this quote, which I thought was just a really helpful and wonderful way to articulate how an interpreter could be helpful and to respond to this common concern or common situation where a family member is maybe refusing to have an interpreter, even when the patient has a language preference other than English. So I'm going to read this quote because, again, I think I can't say it better than he did. There's also a group that they feel they're independent and they don't need an interpreter, so you have to negotiate with them. Most of the time when I talk to them, I tell them, okay, all of us, we speak English. The problem is medical lingo is difficult to understand. My concern is that you're listening to a conversation with the doctor. There's a word that you don't know. You start to wonder, what is this? When you come back, you lose track of the conversation. So let me help you, and you do your part, which is taking care of your loved one and listening. So you can take any decision and do whatever is needed. That usually puts people at ease. People then don't get offended. They work with us and they do really participate in a better way to do the treatment of the patient. What I really love about this approach is it is really centering our desire to help this encounter go as well as possible by, again, offloading some of the burden from the family member and actually helping them feel like they can be a better advocate for the patient. So I think that's the key part here is you're still providing this way in which you understand that the family is trying to do best by the patient. So this is the way in which they can best advocate for the patient is by being a family member in the conversation and then allowing an interpreter to do that task of actually interpreting what is being said. Okay, so when you have identified that a patient needs an interpreter and you have arranged for an interpreter, whether that's in person, video, or over the phone, some best practices to think about. Before the meeting, pre-meet with the interpreter. This is critical. It provides a chance for you to give the interpreter a heads up, right? What's the purpose of the discussion? You can give them a little bit of basic information about the patient's condition, again, especially when we're talking about serious illness or critical illness, or even things like being hard of hearing, memory loss, cognitive impairment. Those kinds of really key pieces of clinical context can help the interpreter feel more effectively interpret in that interaction. It also gives you a chance to ask the interpreter if there are any relevant cultural norms or linguistic nuances that would be helpful for you to know in light of the purpose of the discussion that you've mentioned. Sometimes the interpreters may have worked with a patient and family before, or they may have some other ways of describing certain things that have worked well, and that information can just help you and make it a little bit easier for you to do a good job in the conversation. So that being critical. And this doesn't have to take long. This can be a 2-minute check-in before going into the room or before starting the clinical visit to be able to talk with the interpreter about that. As you're in the middle of the conversation, you really want to be avoiding medical jargon, really thinking about explaining things in as simple of a way as possible and breaking sentences into shorter segments so that the interpreter can keep up with you. The longer you keep talking before they can say something, the more the chances that the interpreter is going to miss something. You want to focus on the underlying concepts for complex terms. So rather than getting hung up on some of these specific words, again, recognizing that there may be no equivalent term in that language, you really want to try to explain what you're talking about, right? Hospice is really a philosophy of care that's focused on quality of life and helping people to live as well as they can for the time that they have, that kind of language. So the underlying concept rather than getting stuck on the term itself. And then this, I think, is really important. You really want to use empathic statements as you normally would. In data that I didn't show you that was from some ICU family meetings here at Harborview Medical Center, analysis found that the thing that got cut out of interpreted family meetings was the emotional responses, right? So the kinds of statements that clinicians would say that would build trust and rapport and acknowledge that this is a difficult, hard situation, that's what people were cutting out. And that's critical to establishing trust and helping people navigate these distressing situations. So use empathic statements as you normally would. Check for patient family member understanding, thinking about those tried and true primary care clinical skills around things like teach back. So again, you have this kind of game of telephone that is happening now in the conversation because of the presence of the interpreter. So it's extra important to think about these ways in which you can kind of check to see if that message really did make it all the way through that you were trying to communicate. So really thinking about using some of those methods in these interactions with interpreters. And then after the clinical visit or encounter, again, this can be very brief, but having a little bit of a debrief or check-in with the interpreter, particularly when we are talking about serious illness conversations, they can be heavy, intense, a lot of hard decision-making that's happening, or high-intensity decision-making, high stakes, that's the word I was looking for, high-stakes decision-making that's happening. It can be hard on the clinician. It can be hard on the interpreter too. The interpreter is the one who is actually saying the words. So if you are in a conversation and you're breaking bad news, for example, the patient is actually hearing that breaking of bad news from the interpreter, right? They're the one actually saying those words. So it can really take an emotional toll on them as well. And one of the things we keep hearing about is that often care team members are not providing the interpreter a chance to kind of process that emotion the way we might do with our own interdisciplinary team members. And then, of course, consider providing as well as asking for feedback so that you can kind of continue to improve your skills and also provide the interpreter with some ways in which maybe they could do a better job. Okay, so because I think this pre-meetings concept is so important, I pulled a couple of quotes from, again, our own research where we've been interviewing interpreters to give you a sense in their own words what a big difference this makes and why it's so important. So here's a Vietnamese interpreter saying, "Some say I'll give you some background and here's where we're at." That helps a lot, right? But the reality is that many interpreters are not doing that. And when they're not doing that, I interpret, but I don't feel like I completely understand the whole picture, right? You can kind of imagine the interpreter is kind of in the dark then trying to do their job in the midst of a conversation without having that clinical context or other pieces of context. This Chinese interpreter, and this is actually, this individual is talking about a video interpretation session. So I know it can feel maybe a little easier to do the pre-session when you have an in-person interpreter. And I will say that for palliative care conversations, the preference is definitely an in-person interpreter. But even when you're working with a video interpreter, you can still have this touch point, right? So here the interpreter is saying on the pre-session, give us a little bit of insight. But not all the providers do that. But in this example, the provider said, here's the patient, and that's her name, right? So you can see this is happening in the patient's room. Here's the patient, and that's her name. But just so you know, she has memory issues. So right away, I know it's a dementia session, right? So again, this is taking less than a minute, but providing the interpreter critical information. And I would even go as far to say that when we talk about dementia specifically, one of the key things is to give a sense, to be able to talk with the interpreter, that you want them to interpret everything the patient is saying, regardless of whether that is kind of making sense or not, right? And that may be because you're really trying to get a sense of the patient's cognition. And so that's another kind of tricky issue that has been coming up in some of our own data collection, interpreters talking about how they don't know how to navigate those situations. And it would really be helpful to have guidance from the clinician or the care team member about how to handle that. And then finally, the Spanish interpreter saying it's like we get dunked in ice water, every single patient, because we don't know what we're going to talk about. Okay, so I'm going to move to the last section of this talk, which is now really thinking beyond the clinical encounter, right? So that was really thinking about when you were in that interaction with that patient and family and you're working with an interpreter, how can you do that well? But now I want to kind of zoom out and think about if we are really to address disparities for these populations, what are some of the multi-level approaches that we can take? What are some of the targets for intervention? And that gets me to introduce the CCM program, which is based at Harborview. It was started in 1994, so it's been more than 25 years. And this program now has grown to more than 10 CCMs representing the languages that you see there. I'll just make a mention that if you want to learn more about this program, the Ethnomed website is a great resource in general for content around culturally and linguistically diverse populations. They have a lot of great content about different groups, including videos that are culturally tailored and in different languages. But anyways, so the CCM program, these bicultural caseworker mediators are full-time staff within interpreter services. They act both as interpreters, but also do many more things that I'm going to show you on the next slide. What's interesting is they have this kind of like one foot in the healthcare system as full-time staff and the other foot in the community. So in their role, they even get time to do community education, to be a part of community organizations, to really have that strong connection with the community. And that kind of dual role really, I think, allows them to help patients in a way that is far greater than when we talk about interpreters themselves. And so in work that we did to try to better understand what are the different types of tasks that the CCMs are doing and how are those addressing these multi-level drivers of disparities for this population, these were the kinds of things. So in addition to interpreting, they're providing advocacy. They're advocating for patients and families to the care team. They're helping the patient and family navigate the healthcare system. They're doing care coordination, right? Making sure that the patient's follow-up gets scheduled, making sure that that patient has transportation to get to the appointment. Mediation. So in addition to just interpreting in the middle of a, let's say, an ICU family meeting, they're also actually helping to give some tips to the clinician to better navigate the situation. They're trying to advocate for the patient and family. They're really trying to mediate those conversations and really are able to kind of build trust, I would say, especially when trust has been fractured. And then provide a lot of emotional support to patients and families as well. So you can see it's kind of this interpreter plus patient navigator who's able to much more meaningfully, I would say, help patients and their families navigate the healthcare system. The CCMs are generally appropriate when you have a patient who speaks one of the languages that they represent and has a complex social situation, has complex medical conditions. So again, we see a lot of this in the context of serious illness, where there may be many providers that that the patient is seeing, and a lot of kind of complex care issues, as well as challenging family dynamics, emotionally intense conversations, things like that. Anyways, in doing all of these tasks, it really allows the CCMs to enhance relationship building between the care team and the patient and the family. They're actively troubleshooting cultural barriers and problem solving. That might look like bringing to the primary care clinician's attention that this patient with diabetes is fasting for Ramadan and that's affecting their blood sugars, so that then the clinician can manage that effectively. They impact knowledge of cultural issues, so that would be an example of that one for the clinician, but they're also helping the patient and family understand our complex healthcare system. And in this way, they really bridge the patient, the family, the healthcare team, the community across all of their work. Okay, I did want to mention the research studies we have going on, because now I'm going to share some more quotes with you, and it will help you to understand where those quotes are coming from. So we have these two studies that are going on right now where we're trying to identify targets for multi-level interventions to improve palliative care across a couple of specific language groups, one study on dementia, one study on cancer. Okay, so in the course of that work, we have been interviewing patients and family members, interpreters, clinicians, community-based organizations to try and understand what are the barriers and facilitators to high-quality palliative care for populations with who prefer a language other than English. One of the key takeaways from that work, as we think about things that we can be intervening upon or kind of improving upon, to me was around how we frame palliative care. And I would say that while most of my talk has focused on the language part, this theme, I would say, really taps into culture as well. The Somali CCM here saying what they really like about palliative care. One is that they do communication better because they can communicate to other care teams. So again, when we're thinking about serious illness, there may be a lot of different providers involved. Not everybody's on the same page, and palliative care can really help with that. But more importantly than that, they go on to say they can lessen the burden of the family and give them ideas of their goals of care. It is the right time to maybe go and visit Somalia or to see some family members. And then this is the part that I really want to highlight here. They go on to say, and towards going to end of life or talking about it, how to make the person's, the disease they have to live better. Now, what I would say is one thing I hear about a lot from clinicians when it comes to finding it hard to bring up palliative care, particularly with patients from different cultural backgrounds, whether or not there are language issues involved, is this finding it difficult when people are really focused on prolonging life. How do we talk about this quality of life piece here? And I think this is such a wonderful example of how we could do a better job framing palliative care in a way that really resonates with people and is much more culturally responsive and still is true to what palliative care is, which is at the end of the day, what we are trying to do with palliative care is to help people live better for the time they have in the context of serious illness. And so that's kind of the reason to show you this quote, is as an illustration of how we can think about doing a better job communicating what is a really hard thing to understand, palliative care, in a way that can still connect with people regardless of their cultural background or kind of where they're coming from. I think this message kind of connects across the many things that may be different between different groups. Okay, so that was one, thinking about how we frame things like palliative care. The second one is thinking about, again, kind of from an intersection of culture and language and literacy, how we can be clearer in our communication to ensure illness understanding and ultimately facilitate goal concordant care. And here I think the Spanish CCM talks really nicely about the way in which they and the palliative care team partner to have that communication, right? So here the Spanish CCM saying, the definition, so that day I remember her, the patient always asking, am I going to get better? This is a patient with cancer. The definition of getting better was tricky. And I always, with palliative care, talk to her about what getting better really means. Are you asking if your cancer is going to be cured? Or are you asking if you're going to feel better even though the cancer is not gone? She understood what was going to be done because we were very clear and we explained to her how far the cancer had gone, what could be expected in the future for her, honest and transparent. That's what we were for her. I'm very proud of working with palliative care with this patient and others. So just a nice illustration, I think, of when we try to work together with the interpreter. Part of that is that the interpreter understands kind of our purpose with the conversation. What are we trying to achieve here? And here it's ensuring that the patient fully understands what is going on. And in that case, the patient being able to then make decisions that are fully informed. So clear, honest, transparent communication, partnering with interpreters to do that. And then really kind of highlighting the issues around healthcare system navigation. Here, a Spanish interpreter saying, people have to deal with new cultural challenges being in the US, and they need more hand-holding. This is hard because the focus here is on empowering people. But people need help, even if they are capable. Providers need to be mindful of this. And so here, I think, is where we need to think about going beyond just providing access to interpreters to really thinking about how we help patients and families navigate our complex healthcare system, which is so much harder when you don't speak the language. And then finally, last quote here, from this Vietnamese interpreter highlighting how our lack of community resources is so challenging for these populations. So the physician offers some community resources. This happened to be in the context of dementia. but the resources is also in English. And that's why the daughter was looking at me to say, I don't understand these resources. How do I seek help from this paperwork, this website, right? So if we don't have culturally and linguistically appropriate resources, how can we expect people to effectively navigate chronic medical conditions, serious illness? Okay, so pulling all of these pieces together, I just want to give you a sense of kind of what I think about as potential next steps and targets for intervention so that we can do a better job as we're taking care of these patients and families. So one is thinking about communication skills training, right? Can we start to develop more training to help clinicians more effectively work with interpreters? That includes thinking about how do we reframe things like palliative care in a way that is more culturally appropriate and can be communicated, with the nuances around language. Training for interpreters. Interpreters talked to us about really wanting to feel like they had more skills for navigating serious illness conversations. So thinking about in the way that we train our clinicians about what's a goals of care discussion and what are frameworks for having that conversation, being able to do some of that training with interpreters so that they understand what we're trying to accomplish and why sometimes we're approaching conversations in the way that we are. And then, of course, I mentioned the pre-meetings. So thinking about, are there more structured approaches where clinicians and interpreters can start to work together, where we can feel more like a team and less like the interpreter is a tool that we're using? And then, of course, developing culturally and linguistically appropriate resources, and then thinking about these programs that really move in more of a patient navigator model to combine interpretation and navigation. Okay, so just checking how I'm doing on time, which looks good. So in summary, patients with limited English proficiency, preferred language other than English, and serious illness experience disparities in multiple domains, including things like symptom management, information needs, and decision making. Interpretation is a fundamental part of any intervention aimed at providing equitable care to this population, right? We have to make sure that patients can understand what we are talking about, and we are doing our due diligence to provide them with qualified interpreters. And just access to interpreters alone is not enough to address the multi-level drivers of inequities for this population, right? That patient still needs to schedule to make an appointment. That patient is still trying to understand what their lab results might mean. There are so many things that go beyond just that interaction between the patient and clinician in the visit itself. And of course, the one thing I want you to really take away from this whole talk is if you are working with an interpreter, take 1 minute to check in with the interpreter before the conversation to tell them what the goal of the conversation is, some clinical context, and ask them if there's anything you should know from them. And then I want to kind of highlight how programs like the CCM program are an example of the kind of intervention that can really address multi-level barriers, right? Again, they're going beyond to think about things like navigation and care coordination. How do you help advocate for patients and families, et cetera? So that's my concluding point, that we really need multi-level interventions to improve palliative care for these populations. And I hope that through my own work, I can make some small contribution to that area. Okay, so final quote, just to, I think, as a good palliative care clinician, drive home the idea of holistic care and whole person care. When asked about kind of what guidance would you have for clinicians to provide better care for these populations, this Somali CCM said, see me, meaning the patient in this case, see me as a human. See me as just somebody like you. See me like I'm someone without disease, and then let's talk about the disease. And when you walk in that door, know that this person had a life before immigrating here. I remember one of the doctors. I told him he was shocked. I said, she used to be our best basketball player of our national team, this woman. Do you know that? So just a reminder that an immigrant identity is not all that makes up an individual. They're a combination of many intersecting identities and life experiences, and just to try and remember there's a whole person, and we're trying to meet them as a person. So, on that note, I would welcome questions or comments. I'd love to dialogue with you all. If there are certain cultural challenges or linguistic related challenges that come up as you are interacting with patients and families, I'd love to hear about those, and we can kind of chat about some ways to address and do a better job with those. So, thank you.
Thank you so much. This was just incredibly helpful. I find the discussions and learning about limited English proficiency and working with interpreters to be accompanied by such amazing insights. But then when you add on the context of palliative care, there's so much more. And while people are thinking of questions, I have a question for you, and that is, to what extent are the interpreters challenged or experienced with palliative care discussions versus other kinds of interpretation that they might be doing?
That's such a wonderful question, and it's a whole spectrum. And I think that's an important thing to be thinking about as a care provider, is that every interpreter that you are working with may come with a varying level of skill and experience. And in that pre-meeting, I think is a helpful time to kind of get a little bit of a sense of that. I think for interpreters who are very skilled, and in some of our interviews, some interpreters told us that they actually find some of those visits and encounters to be the most meaningful. And they're kind of drawn to those types of conversations. With that kind of interpreter, they can be a much more effective partner with you. Whereas someone who really has very limited understanding, you really need to be sure that you are very clearly describing the underlying concepts of something that the interpreter likely doesn't understand, like the difference between palliative care and hospice, right? Like, you really can't take much for granted in terms of how you're explaining things. You really need to use more of those teach back methods and think about the language that you're using. So it does indeed require, I think, being able to adapt and acknowledge that right now the interpreters are not required to have a certain amount of palliative care training, and some choose to get some. So it's a whole range.
That's interesting, because my follow-up question was going to be, I used to live next door to a woman who had been trained and then qualified and authorized to be an interpreter, and I just was wondering to what extent the focus on palliative care discussions gets rolled into that training. So it sounds like it might not, right?
Sometimes it might be very light on the palliative care piece.
Okay. Are you aware of other programs in the Puget Sound area similar to the CCM program? It sounds like what I have wanted in many situations. That comes from Mary Zeitner.
Yeah, Seattle Children's Hospital has a program that is kind of similar in that it is a bit of a kind of mix between patient navigation and interpretation. So that's the program I'm most familiar with that is sort of in that direction. I will mention even within UW Medicine, so when we think about our main medical center, our Northwest campus, the VA hospital, there, the CCM program is only at Harborview. So even within our own health system, I would say many of us similarly wish that that program could grow and be more resourced.
Interesting. So Xin Yi is saying, I hope I'm pronouncing that right. Thanks for the information. I agree with you, and I found interpretation is often overlooked and among limited resources. From my experience, it's done remotely using portable technology at the hospital setting. Also observed that nurses using Google Interpreter for this. What is your thought on AI interpretation, side-by-side caption, live interpretation? I could see that. She says I could see that as challenging in the palliative care setting.
Yes, that's so interesting because this very topic came up in a conversation I was having this week with one of the interpreter services administrators who does a lot of the training for interpreters. And she was talking about all the work that they have been doing around translating discharge instructions, and that many providers use Google Translate, and they used Google Translate to look at kind of the output of discharge instructions and found a lot of errors. And the example she gave to me, and I'm not a Spanish speaker, the example she gave to me was that the phrase kind of hold this medication is common, right? If you're supposed to avoid taking a medication, say, before surgery, and that was being translated to maintain.
Mm.
So you can imagine don't take a medication is quite different from keep taking the medication before surgery. So that was an illustration that even for Spanish, which we typically think of as the translation kind of capabilities being better, that important errors could still be happening. So I think she was really saying that she spends a lot of her time cautioning clinicians from using Google Translate. I would say I'm really interested in thinking about how AI tools could help augment actual interpreters or trained interpreters or increase access to interpreters. And it makes me nervous to think about the ways in which they could be used instead of an interpreter. And you are right to point out that for palliative care conversations, where there's also rapport building, responding to emotion, and challenging topics, that can be especially hard to rely on something like Google Translate. A lot of nuance would get lost.
Interesting. So Rabelais is asking, what are some reasons why people whose interpretation is often overlooked don't include solutions?
I am not sure if I'm fully understanding. I'm fully understanding what you mean by
Maybe it relates
solutions.
to whether those people have an awareness that their interpretation is being overlooked and so they're not working on
Oh, I see.
solutions. I'm not sure, Rabelais, if that's what you were wanting.
If that's what you're wanting, then I
Yes.
would, yes, okay, thanks. I think it's really important to recognize the power differentials, right? So oftentimes when we're talking about individuals, they may be already feeling like they are at a disadvantage and not in a empowered place where they can stand up for what they need, and what would be helpful for them. So I think that power dynamics that exist in healthcare can make it especially hard, especially as in many cultures, healthcare professionals are really highly respected and seen to have kind of a place in the hierarchy. So again, they may be especially hesitant or fearful to kind of bring up and mention that they don't understand something, and that then it reflects poorly on them, right? Like they're not smart enough to understand what you're saying or to kind of speak up for what they need. And also, people might be concerned about costs of and not know that interpreter access is provided free.
So I'm putting a comment in the chat that I'm hoping all attendees will take a look at, and feel free to contribute in the chat to try to understand sort of the breadth of experiences that they have in their settings during conversations about palliative care, whether that's with an interpreter or without. What have been some of the challenges or surprises that they've experienced in their settings? So I'm hoping, folks, you'll think about that and quickly, but let us know in the chat and let us know the setting that your perspective comes from.
So seeing the question about if interpreters also provide written documentation to patients and families. Here it says I always think about the difference of being bilingual versus biliterate and getting recommendations, instructions in their preferred written language has been harder. Yeah, that's such a wonderful point. I really appreciate Rebecca, you bringing that up. I would say that um, there's definitely been effort within our health system to do a lot of translation work on common instructions and plans as one way to try and help with that. I would also point out that in a lot of our own work, we found that literacy can be a big issue and that individuals may have low literacy, or for some languages that are really based more on kind of oral traditions, people may be fluent but not able to read in their native language. And so that can be one of the challenges around written recommendations. I think that's another place where things like technology could be really helpful. And thinking about ways where maybe you can hear the instructions. So that's something that I think could potentially help.
So I'm not sure how I'm going to frame this, but I wanted to share an experience that I had in the clinical setting. This was quite a while ago. I worked in coronary care up in Anchorage, Alaska, and received into the unit an older man from one of the villages up north who was in complete heart block. And so there was a lot of effort to try to kind of provide information, get him settled, and also think about some of the possible implications of the complete heart block, which actually is more common in Alaska natives than one might think, and they do very well with it. So it's not as worrisome as it might be in other populations. But the clinician who accompanied him, as I was trying to talk with the patient, said, "Oh, let me talk to him. I can, interpret." And then his interpretation ended up being speaking incredibly loud, incredibly slow, and incredibly simply,
Ugh.
but not addressing those kinds of things. So my question to you, Dr. Sharma, is how might you think of giving feedback to an interpreter, perhaps outside of that specific engagement, but to sort of help the interpreter move or progress along in their work? I don't know if you get what I'm asking, but it was a delicate dance, it seemed like, for me, and yet I thought it was important also for the benefit of this patient and other patients for some feedback to go back to the clinician about helping us to work together on understanding.
Yeah, totally. I find sometimes using terms like I noticed can be a way to open up that conversation. So that might look like something like, I noticed the patient seemed to not fully, you know, understand what we were talking about. And I wonder if a better way to approach, an interaction like this next time might be, A, B, and C.
Mm-hmm.
As maybe, because you're right, I think it can be tricky. You don't want to make that person feel super defensive, but you also want them to then not do the same thing again. So, I think sometimes some of that language and some of those I statements can try to provide you a little bit of that neutral tone. I think the other thing from a palliative care perspective, we're always trying to orient things or ground things in shared goals. So it's kind of like we all want to feel like the patient has a good understanding of what we're talking about.
Mm-hmm.
And, I think this other approach or strategy might be more effective or helpful in doing that.
Okay, thanks. Janelle is saying it's a challenge reaching patients to convey abnormal
Ah,
results and a lack of real time or timely interpretation if we send a letter as a last resort. And she's hopeful that AI will be effective technology over time to aid clinician communication in preferred languages, but maybe we're not there yet.
Yeah, I've heard that there is some work that's starting to happen in some of these platforms. So especially when we think about patient portals, that's a place where there's huge disparities because patients can't then access test results or understand those results in the way that another patient could. So I agree that I think, so I'm hearing about some work to try to think about how to incorporate translation tools into things like patient portals and Epic. Um, I think that would be super helpful. And I do think that, in contrast to what I was talking about earlier around how, the problems with relying on Google Translate, I think there are still some places that are not, complex, nuanced conversations, but some more basic things where some of that translation could be really helpful. And especially ways where people could make appointments, for example, right through the online and being able to have access to that information in different languages.
Interesting. Yeah. We've got a long way to go, that's for sure. Any other questions,
I
folks,
know.
or interest or willingness to contribute some perspectives from your setting? Maybe what's been the focus of palliative care discussions based on, what brings you with the patient, your discipline, whether it's a social work, physical therapy, pharmacy, nursing, physicians. What's generally been the focus for you to engage in these palliative care discussions where there might be limited English proficiency? Do you step in with a group to sort of help that, or is it each person that's part of the healthcare team as they interact with the patient have those discussions?
I really like this point around using the iPhone screen reader
Yeah.
feature to help patients hear messages. I think that's great. I think that's a really nice strategy around some of the issues with written language. It reminds me that one of the other challenges that I really didn't speak to is that for patients who are hard of hearing, which again, kind of something we think about with older adults and geriatric populations, that telephone interpreters, which are still the most accessible type of interpreter, can be especially challenging.
Mm. Do some of these translator programs that might be screen read show text in the person's own language, whether, like characters and that sort of thing? And is that great, or has it been problematic, or we're just not there yet?
Think, yeah, that's a good question. I haven't myself used many of these. Um, I keep hearing more recently about work for the kind of like earbud
Mm-hmm.
translators or kind of skipping over some of this
Mm-hmm.
and moving to kind of more direct translation, in an audio way, which is interesting.
Mm-hmm. But I think there also could potentially be an assumption that someone who has limited English proficiency also has limited literacy in terms of
Uh-huh.
reading literacy in their own language, and that might not be correct.
Very true.
Yeah.
Yes, that's exactly right.
Well, I think we've had some good discussion here. I can't tell you how much I appreciate the information that you're sharing. It's just so important, and particularly within this context of palliative care, so critical because the nuances within everyone's specific language are profound and difficult to
Yes.
translate. So, thank you very much. Everyone, we will see you next week. Our lecture next week is going to be focused on wellness in general, and I hope to see you there. And thank you very much, Dr. Sharma. Just invaluable information.
So much for having me. I hope this was helpful to everyone.
All right. Good night, everyone.